for joining us by Zoom. It's my pleasure to introduce Dr. George Wang. Before I get to Dr. Wang, I just want to mention, so this presentation is jointly hosted by the Center for Long-Term Care and the Department for Public Health. On October 15, the Center for Long-Term Care will have a half-day colloquium on aging in place. So we have, if you haven't seen the flyer for that, I'll pass that along. We have a really good lineup of speakers, including a keynote by Master Yang, who is one of the country's preeminent Tai Chi masters. I'll just pass that around. So Dr. Wang is an integrative medicine physician and geriatrician who champions food as medicine as part of a holistic approach to healing. And I've gotten to know Dr. Wang over time. He's a vegan, just like my wife and daughter, so I'm trying to understand that world a little bit better. Prior to founding Wisdom Health and Wellbeing, an integrative medicine practice in New Jersey, he was on the full-time medical faculty at the Johns Hopkins University School of Medicine, where he directed an NIH-funded laboratory that focused on the aging immune system, and he was also on the faculty at Columbia University Medical Center. His peer-reviewed research has been published in Science Translational Medicine, Nature, American Journal of Epidemiology, and Journal of the American Geriatric Society. His writings have appeared in the media, including CNN, The Conversation, Civil Eats, and The Hill. He was formerly the medical director of the Sussex County Translational Care Program and director of the Center of Excellence in Geriatric Medicine at Newton Medical Center. Dr. Wang currently provides medical care to patients at Wisdom Health and Wellbeing and is adjunct assistant professor of medicine at Johns Hopkins. As I mentioned, Dr. Wang founded Wisdom Health and Wellbeing. His presentation today is Cognitive Impairment and Alzheimer's Disease, Integrative Approaches to Prevention and Treatment. Thank you, Dr. Wang. Thank you.
Thank you, Dr. Knapp. And good afternoon, everybody. It's a real pleasure for me to be here. That was a kind introduction by Dr. Knapp. Just want to tell you just a little bit about myself. Dr. Knapp asked me to do that a little bit. I was conventionally trained in medicine. I did my geographic fellowship at Johns Hopkins and joined the faculty there. And while there, I ran an NIH-funded lab focusing on aging immunology. And as part of NIH support, traveled to St. Jude Children's Research Hospital and received mentorship from Dr. Peter Doherty, who received the Nobel Prize for his discovery of T-cell mediated immunity against virus-infected cells. And a few years back, I moved back to New Jersey in order to be with my family and joined a community practice there. And it was around that time when my mom was diagnosed with breast cancer, which then prompted me to really explore in depth holistic and integrative approaches to cancer healing. And as a result of that journey, I became board certified in integrative medicine and licensed in acupuncture, which is something I've enjoyed very much practicing. I later joined Columbia University Medical Center in New York City, and a wonderful institution. I felt though that I wanted to practice medicine in a way that I could address the root causes of diseases, and I decided to start my own medical practice. So Wisdom Health and Wellbeing, which is in Short Hill, New Jersey, which is an integrative and functional medicine practice that allows me to help people heal at the root cause level. And since doing that, I've really enjoyed practicing medicine this way. It really reminds me why I became a doctor in the first place, and it completely aligns with my values and how I feel is really what the healthcare system means in terms of how to deliver healthcare in an optimal way. So that's a short summary of how I came to where I am today, and the focus of my talk today is on cognitive impairment and Alzheimer's disease and holistic, whole-person approaches to preventing and treating this disease. So just a little bit of disclaimer, in a talk like this by a doctor, it always only serves as general information. It doesn't create a doctor-patient relationship between me and the audience. And none of the information provided here should be interpreted to constitute diagnosis or treatment recommendation. If you're looking for medical advice, please consult your physician or a physician. So these are objectives of the talk. Recall mechanisms of pathogenesis in cognitive impairment and Alzheimer's disease. And I'll discuss some current pharmacological treatments, recognize risk factors for developing cognitive impairment and dementia. I'm going to talk about some preventive strategies, and I'm going to outline for you a whole person approach to caring for Alzheimer's disease. So this is the scope of our problem. Worldwide, as of 2015, there are more than 40 million people with dementia, and that number is expected to more than triple to 140 million in 2050. In the US alone, there are more than 5 million people with Alzheimer's disease, and that number is going to increase to almost 14 million by 2050. It's now the 6th leading cause of death in the US, and a third of all the people now die with dementia. And an interesting perspective is that every 65 seconds, someone living in the US develops Alzheimer's disease. And it's alarming to note that of all the leading causes of death, Alzheimer's disease is the only one that does not have a disease-modifying therapy. And by disease-modifying therapy, we mean a treatment that favorably changes the course of the disease. And as you are all well aware of, there's, despite billions and billions of dollars we've put into pharmaceutical research, we don't have a single agent or vaccine that reverses or even halts the progression of Alzheimer's disease. Well, in medical school, we learn very well from case examples, so I thought I'd give a case example of someone with Alzheimer's disease, and this is coming from the literature published by Dr. Dale Bredesen. This is a 66-year-old professional man who had senior moments, forgetting things, difficulty in his work. He does have a family history, as I mentioned, in both his parents. He does have the ApoE4 gene, and I'll talk a little bit about that in a bit. His imaging study, amyloid PET imaging, was markedly positive, highly suggestive of dementia due to the Alzheimer's type. PET scan was also highly suggestive of Alzheimer's. His brain MRI showed his hippocampal volume was only at 17% for his age. And early on, he had formal neuropsychological testing, which was compatible with a diagnosis of MCI or mild cognitive impairment. He started the Bredesen protocol, which I will discuss in detail later in the talk. Lost 18 pounds as a result of that. And after just 3 months, his wife noted that his memory had improved, and he was able to function much better at work. But after 5 months, he decided to stop this program, and then there was one episode where his wife came home to find that he had left his car idling in the garage, and he completely forgot about that. So he reinitiated the program, and he had no further such episodes. And after 10 months on the program, he had a follow-up MRI of the brain, which remarkably showed an improvement in his hippocampal volume from the 17th percentile to the 75th percentile, and he had marked symptomatic improvement. So as a geriatrician, that's a pretty remarkable case. In all my time practicing conventional medicine, seeing Alzheimer's disease patients with patients with MCI, we don't ever see that type of improvement. Is there a way we could, I think we probably want to minimize this so we can see there we go. So this is a spectrum of cognitive status. All the way on the right you have normal cognition. And we have what we call subjective cognitive decline. So this is diagnosed when someone, a patient or individual, complains of cognitive impairment, but on screening instruments in the office or in research setting, we do not find a abnormal score. And mild cognitive impairment, or MCI, is essentially a person complaining of cognitive symptoms and also scoring abnormally on the screening instruments such as the MOCA or NYMC. And then dementia is essentially someone, such as the person with MCI, scoring abnormally on the screening instrument, plus having some difficulties in daily activities or social function. And many patients do come with subjective cognitive decline. They will say that they've noticed for the past several months or past year or two, they felt that their memory hasn't been what they used to be. They might be forgetting things, but often these people are highly functional and they score perfectly on the screening instrument. So what we think in that instance is that there's already pathology going on in the brain, but our current instruments are just not sensitive enough to pick up those pathology. So perhaps future down the road we have more sensitive screening instruments that can pick up the pathology in those people. Okay, the arrow is not working. Here we go. So dementia is really just it's an endpoint, it's a manifestation. Dementia is not a disease per se. There's many paths that can lead to dementia. Alzheimer's disease is just one of those paths, but it's the most common cause of dementia. It accounts for 60 to 80% of cases of dementia. Vascular dementia is also very common, but the sole cause of dementia accounts for only about 10%. And the majority of those cases in older adults, 50% of them occur in mixed pathology with another type of dementia. Dementia with Lewy bodies is also another common cause. And in fact, the most common pathology we find in older adults is mixed dementia with features with more than one cause. Often we see that with vascular dementia and Alzheimer's dementia. And then there are more rare causes of dementia, such as frontotemporal dementia, Parkinson's disease dementia, Creutzfeldt-Jakob disease, and NPH, or neural pressure hydrocephalus. The remainder of the talk, I'm going to focus mainly on Alzheimer's disease. The average duration of illness from the time of diagnosis of Alzheimer's disease is about 8 to 10 years, but the actual pathology probably already started way before that, 10, 20 years before that. The mean age of onset of 80. It is often to find comorbidities, or especially cardiovascular or cerebrovascular comorbidities in this population. And it's not unusual to find family history of people affected with Alzheimer's. And it mainly results from the failure to clear the amyloid beta peptide from the brain tissue. A less common form of Alzheimer's disease is the autosomal dominant. That accounts for less than 1% of cases. And unfortunately, if someone carries that gene for this, there's already case of age of onset between 35 and 50 years of age. It's due to the genes encoding APP, PS1, and PS2, which result in a overproduction or a aberrant form of amyloid beta. And people with these mutations have a nearly 100% risk of developing Alzheimer's disease early on. So this is the type of pathology that happens in the brain of a person with Alzheimer's. You have the amyloid plaques. These are extracellular protein depositions, as well as tau proteins, which form neurofibrillary tangles within the cells. This is a very nice graph showing the time course of biomarker changes in relationship to the symptoms. So the y-axis, the time, is all the way to the left. You have That's essentially preclinical stage, non-Alzheimer's preclinical, and then you have very mild Alzheimer's, moderate, and severe. And so if you focus on the line where it says amyloid plaque, you can see that even before a person develops any clinical symptoms, amyloid plaques are already building. So the amyloid plaques are found in normal older adults. Neurofibrillary tangles lag behind a little bit by about 5 years or so, and it starts to build up. And if you look at this line, neuronal integrity, which goes downward, you can see that neural integrity starts to decline only when you reach a certain threshold of amyloid plaques and neurofibrillary tangle. And when neural integrity declines to a threshold, then the person starts to manifest symptoms of mild Alzheimer's disease. So there is a window of opportunity to intervene when patients have pathology in the brain but have completely no symptoms at all. But these are examples of amyloid PET imaging. The image on the left represents the image for a person. These are both people with mild cognitive impairment. The left is a person where the imaging is essentially normal. And this person, after 4.5 years, remains stable without any progression of cognitive decline. The person on the right, though, the imaging was positive on the red and orange areas, and this person did develop Alzheimer's disease within 3 years. So the amyloid PET imaging allows us to distinguish at an early stage, potentially, which patients with MCI could develop Alzheimer's disease.
Can I ask a quick question? What are the red and orange?
Those are amyloid binding to the amyloid plaques.
Are we doing questions later?
Yes, I would prefer
Okay.
if we do the questions later because we have a lot of slides to go through. But write it down. So these are the current pharmacological treatments available. Essentially two major drug classes. First is the cholinesterase inhibitors, and examples of those are donepezil, rivastigmine, galantamine. And essentially it works by essentially increasing the concentration of acetylcholine in the synapses, which is the problem in people with Alzheimer's disease. Another second class is the NMDA receptor antagonist, and there's really just one drug in that class, memantine. And it helps to normalize abnormalities in neurotransmission in people with Alzheimer's disease. In reality, though, in clinical practice, we see that the use of these medications really results in very subtle or not appreciable clinical responses. And that the reason for that is pretty obvious because these drugs are really not addressing the root cause of the problem. So, with all the money invested in developing Alzheimer's drug therapy, why have we failed? There are some hypotheses proposed in the literature by experts in the field. One hypothesis is that we're targeting the wrong mechanism. Second hypothesis is that the drugs are not engaging the intended targets that we wish them to target. And the third is that the drugs are hitting the right targets, but we're just using the drugs at too late a stage. So too advanced the disease and too much damage has been done for us to reverse the damage in the brain. But I propose also an integrative medicine perspective as an answer to this question. We know that Alzheimer's disease and dementia in general are multifactorial. These are really chronic diseases that start in midlife. And because of multiple factors that contribute to the disease, we really need more than one drug or one pathway solution to the problem. So what we need is a whole person approach to effectively treat and prevent Alzheimer's disease. We also call that a multimodal approach. I like this quote, and so I'll read that for you. Multimodal therapy approaches that combine interventions aimed at different aspects of disease are emerging as potential and perhaps essential ways to enhance clinical outcomes for patients with psychiatric and neurological disorders. Indeed, for most chronic diseases, multiple pathways are involved simultaneously, making it unlikely that a single treatment will prove sufficiently effective. And this sounds like the statement of someone who is really a holistic practitioner, but I was surprised to find that this was the commissioner of FDA, the agency where you would really think has a holistic approach. So the field is moving forward toward advocating a more whole person, more holistic approach to a chronic neurodegenerative disease such as Alzheimer's disease. So we really need a whole person framework because Alzheimer's, again, is multifactorial and there are many biopsychosocial determinants. Genetics plays a role. Lifestyle choices play a significant role, including dietary choices, physical activity levels. Stressors are very important. And there are many different types of environmental factors we'll touch a little bit on, but that includes even iatrogenic causes, medications, general anesthesia, mold or brain trauma, and also many social influences, unfortunately. And exactly because Alzheimer's starts, the actual pathology starts many decades before the manifestation of symptoms, prevention is really key. And we find that targeting cardiovascular and cerebral risk factor seems to be very important because they are common comorbidities in patients with Alzheimer's disease. So what is the optimal stage for prevention? So with primary prevention, we're really targeting people with no pathology. And I propose that this is really the stage where public health efforts should be focused on. It's the stage where integrative health practitioners or primary care has the most bang for the buck in terms of making significant impact of preventing Alzheimer's and dementia in general. Secondary prevention focuses on delaying symptoms in people with already some evidence of pathology, and tertiary prevention and treatment focuses on people already with manifestation of dementia. So if we're going to focus on prevention, there are two types of risk factors, non-modifiable risk factors and modifiable risk factors. And of the non-modifiable risk factors, these are the factors we cannot change. Age is by far the greatest risk factor for dementia. And so far we can reverse age. But if we pay attention to this issue, age alone probably be a less powerful factor if all the confounding risk factors and comorbidities are taken into account. The number is staggering. 80% of dementias are in people aged 75 years or older. Also, family history of dementia, that's something we cannot change. And having a first-degree relative increases the risk by 10 to 30%. And having two or more siblings increases the risk by threefold. ApoE is the most well-known genetic risk factor for Alzheimer's disease. It essentially plays a role in the clearance and deposition of amyloid beta. There are three common isoforms. By far the most prevalent form is the ApoE epsilon 3. ApoE epsilon 4, or in short, most people say ApoE4, is the one that predisposes to the risk of developing Alzheimer's. So having one allele increases the risk threefold, having two alleles increases the risk 12 times. The concept of cognitive reserve is very important. People with higher cognitive reserve can tolerate more neuropathology without manifesting the cognitive and functional decline. And that's probably related to reserves, brain anatomical reserves or pathways that allow us to maintain that reserve. And there's evidence that lifelong accumulation of these cognitive reserve building activities such as intellectual stimulation, physical activity, leisure activities play a role. So these are the modifiable risk factors for Alzheimer's disease. And these data come from the latest comprehensive meta-analysis on these risk factors with the relative risk over here. Diabetes with a relative risk of almost 1.5. Midlife hypertension is a risk factor. Midlife obesity, physical inactivity, depression, smoking, and low educational attainment. There are other risk factors that did not make the cut into that comprehensive analysis. And these include elevated midlife serum total cholesterol. Late life total cholesterol seems to have mixed results. And homocysteine level is a predictor. Individuals with a homocysteine level more than 14 have almost a double risk of developing Alzheimer's disease later on. So the next few slides I'm going to show data from the Lancet Commission on Dementia Prevention and Dementia Care. Just to give you a forecast of what this data shows, essentially it shows that more than a third of dementia cases might theoretically be preventable. But this is a life course model of risk factors for developing Alzheimer's, for developing dementia, and I'm going to blow up this graph for you. So the numbers in the circles represent the percentage reduction in the incidence of dementia if that risk is eliminated. So for example, if we had eliminated the ApoE epsilon 4 allele, that would reduce the dementia by 7%. In early life, less education contributes to 8% to the development of dementia. In midlife, the risk factors are hearing loss, hypertension, obesity. And in late life, risk factors are smoking, depression, physical inactivity, social isolation, and diabetes. And if you combine all of these, the potentially modifiable risk factors total about 35%. So more than a third of dementia cases are theoretically preventable. There are other dementia risk factors that didn't make the cut into that study. Benzodiazepines are a class of medications that are very prevalently used in the community. Many people use these for anxiety, and people use these for as sleep aids. But benzodiazepines belong in a list called the Beers criteria. That's a list of medications to be avoided in older adults, and yet they are commonly prescribed in the community. And they increase the risk of developing dementia. Anticholinergics also a very commonly used medication, and these are over-the-counter drugs. Everyone can buy them over the counter. Benadryl, diphenhydramine, these are all anticholinergics and really should be avoided as much as possible. Other anticholinergics include medication used to treat overactive bladder. Proton pump inhibitors such as omeprazole, these are also commonly prescribed in the community. Many people who are discharged from the hospital are discharged home with a proton pump inhibitor, and that's another public health concern. There's a prospective study showing that the use of PPIs with proton pump inhibitors increases the risk of dementia. But there are also some other studies that show negative results. These are the factors also increase risk for dementia: air pollutants, pesticides, brain trauma, and secondhand smoking. So this is the opinion of the Alzheimer's Association regarding modifiable risk factors to reduce cognitive decline. So regular physical activity, managing cardiovascular risk factors, a healthy diet, and potentially lifelong learning and cognitive training seems to reduce the risk of cognitive decline. The data that I showed so far are epidemiologic observational data. The next few slides I'm going to show some data from randomized controlled trials. So working on hypertension, the data have shown that treating hypertension does decrease the risk. However, there is a study in the diabetes population that showed aggressive blood pressure lowering actually is associated with a decline in total brain volume. So the take-home point from that is it's much better to lower blood pressure naturally through lifestyle changes rather than trying to lower blood pressure aggressively without addressing the root cause. The use of estrogen hormone replacement therapy, some studies are positive, some studies are negative. Diet seems to play a very important role in reducing the risk of cognitive decline. The best data we have comes from a subcohort of the Integrative trial, which show that using a Mediterranean diet improved cognitive outcomes over 4 years. Other than these, we don't, in terms of randomized control trial data, we don't have a lot of data on diet and cognitive outcomes. So we have a whole lot of observational data. Cognitive exercises, in observational studies, we do see that they reduce the risk of Alzheimer's disease. In randomized controlled trials, there's also some evidence showing benefit. Exercise and physical activity, I'll just highlight the result from the bottom. There's a randomized controlled trial showing that walking for 40 minutes, 3 times a week for a year, compared to stretching and conditioning, increased the size of the hippocampus and improved memory in healthy, cognitively intact adults. Mindfulness practice plays an important role in reducing cognitive decline. Tai Chi has been very well studied. In meta-analysis looking at adults who are cognitively normal, comparing Tai Chi to non-interventions, the effect size was relatively large. But when Tai Chi is compared to another exercise intervention, the effect size for Tai Chi is moderate. And even in cognitively impaired adults, and these are people who have MCI or dementia, Tai Chi still has a benefit, but the effect size was small. There are other non-randomized data on mindfulness practice. There's one study, in case control study, looking at 20 experienced meditators. These are non-monk meditators, Western meditators. Compared 20 of them compared to 15 match control. The meditators had a thicker prefrontal cortex, and this is most pronounced in older adults, suggesting that meditation has potentially can offset age-related opinion. Supplements in observational data, we see that high dietary intake of antioxidants is associated with lowering the risk of Alzheimer's disease. But when these are studied in large randomized controlled trials, they have been negative. So that inconsistency may seem puzzling, but the answer is actually pretty clear if we look at it holistically. The people in observational studies who take these antioxidants in their diet, they generally have a much healthier diet. So if we're isolating these nutritional components, micronutrients, and then giving just one, obviously then that won't make much of a difference. So the important thing is the overall healthy diet seems to be of importance. There are other negative trials as well, prevention trials. NSAIDs did not seem to help. Statins, cholinesterase inhibitors, ginkgo biloba. And again, the fact that Alzheimer's disease is a multifactorial disease, you studying just one risk factor or intervening with just changing one risk factor probably does not do us much good. And this has led to the design of multimodal intervention trials where we're focusing on several risk factors at a time. So the figure study is a Finnish study enrolling more than 1,000 people, older adults, and the intervention included, it's a multimodal intervention, included diet, exercise, cognitive training, and vascular risk monitoring. And over 2 years, people in the intervention group, even though the effect size was small, had an improvement in the cognitive score. The square on the upper back. This is another multimodal intervention, the 3D lab. This study, though, this was again an intervention mostly focusing on cardiovascular risk management. The dementia incidence did not differ between the two groups, but when the investigators did subgroup analysis, they found that participants at baseline who had untreated hypertension did have a lower dementia incidence, and the ones with untreated hypertension who adhered to the intervention had an even lower dementia incidence. So possible explanations for the negative result was that this group was already had a very low risk of cardiovascular outcome for developing cardiovascular outcomes, and the country already had high cardiovascular standards of care. And Also, the population was in older adults 70 to 78 years of age, and most observational data show that it's more impactful to start the intervention at midlife. This is another multimodal intervention, the MAP study. Also looking at several interventions, including nutrition, physical activity, cognitive training, plus omega-3 fatty acids. Over 3 years, though, there was no significant difference. But post-op analyses that combine the groups that received the intervention showed that participants who had a higher risk, cardiovascular risk, did benefit from the intervention. So I really like this diagram, which looks at the potential brain mechanisms for preventive strategies of dementia. This is by Livingston et al. This was in the Lancet. I like this because it shows us the different potential mechanisms of how each intervention can potentially work. So if you look at the blue circle, the increased brain cognitive reserve, those interventions can potentially increase cognitive reserve, including preserving hearing, education, cognitive training, having a rich social network, reducing depression, and exercise. And then the orange circle, reduce brain damage. Those factors potentially reduce brain damage, including reduce obesity, stopping smoking, treating cardiovascular risk factors, exercise again, diet, and then reducing brain inflammation. The green circle on the right, exercise can reduce brain inflammation. Adherence to a Mediterranean diet can reduce brain inflammation, and there it says non-steroidal anti-inflammatories will be NSAIDs. So keep in mind, this is a diagram by authors who are conventional medicine oriented. And I propose that we can improve this conceptual framework from a holistic or integrated perspective. So we know that mindfulness practice from a lot of research data can increase brain cognitive reserve, and mindfulness practice can reduce brain inflammation. Also, Mediterranean diet. Mediterranean diet is really just an imprecise way of characterizing what a healthy diet should be. So the main components of a Mediterranean diet that leads to good health outcomes is essentially consumption of whole foods and avoiding processed foods, and also consumption mostly fats rather than animal foods. So I propose that following or consuming a whole food, primarily plant-based diet, will play an important role in reducing brain inflammation and in reducing brain damage. And instead of NSAIDs, these are aspirins, ibuprofen, Motrin, Advil, Aleve, which have a lot of significant side effects. They can cause peptic ulcers, they can cause kidney damage. Really not a good way to reduce brain inflammation. Instead, we know of many holistic approaches to reduce brain inflammation, including maintaining healthy microbiome. That's the healthy population of bacteria in the gut. And the diet in turn affects the microbiome. So, and the microbiome in turn affects the immune system. So that is a holistic framework for preventing dementia. I'll just touch briefly on MCI, mild cognitive impairment. At least a fifth of older adults have MCI, and half of them will develop dementia in 3 years. We haven't seen anything that not a lot of data in research studies to show that can reduce progression from MCI to dementia. Addressing diabetes might help, but cholinesterase inhibitors, which sometimes are being used, they really have no role in mild cognitive impairment. It should not be used in MCI. We haven't had a lot of multimodal interventions in MCI, but they were really needed to better understand whether these types of multimodal therapies could prevent progression from MCI to dementia. many people with dementia are never diagnosed, and so because they're not diagnosed, they don't have enough time to plan ahead. The family and the patient don't have enough time to plan ahead. So making a diagnosis timely is very important. Another case example. This is a 69-year-old entrepreneur, highly functional, and has had memory loss slowly progressing over 11 years. In 2002, when he was 58, he was not able to recall the combination of his lock. And around the time he had a PET scan, which was consistent with Alzheimer's disease, early Alzheimer's. And he also had a series of neuropsychological testing. These take several hours to do. It's a pain for the patient to undergo, but they are very objective assessment of cognitive status. And he had 3 of these which showed decline over time. He was also heterozygous for the ApoE4 gene, and he had difficulty recognizing faces at work, and really needed a lot of help from his assistants in his daily work. There was one event where he was reading a book, several chapters into it, and then finally realized he had already read the book. Also, he had this remarkable ability to add up columns in his head in most of his life, and he had lost that ability at that time. So he was advised that because of his status of Alzheimer's disease, he should really get his affairs in order, and his business was in the process of being shut down because he couldn't work anymore. And then he started the Person program, which is a multimodal type of intervention, which I'll be discussing. After 6 months of being on this multimodal intervention, his wife noticed that all his symptoms had improved, and he had lost 10 pounds as a result of that intervention. He was now able to recognize faces, and he was able to regain his ability, a lifelong ability to be able to add up columns in his head. And so despite all of those improvements, though, his wife noted that the most remarkable improvement to them was the fact that his memory has been rapidly declining over the years, and that has stopped as a result of the program. His business, instead of being shut down, was now growing, and he was now adding more sites to his operation. And the neuropsychologist that evaluated him over the years pointed out that in his 30 years of practice, he had never seen the improvement in neuropsychological testing. But in this man, he was surprised to see such dramatic improvement. So if you haven't read this book, I highly recommend getting a copy. It's by Dr. Dale Bredesen. This was just published at the end of last year, end of Alzheimer's. Dr. Bredesen is a neurologist, UCLA professor, and research in Alzheimer's disease for decades. So this is a picture showing, comparing what a normal neuron looks like and a diseased neuron in Alzheimer's patients look like. So you have the amyloid plaques in the intercellular space and neurofibrillary tangles. So amyloid beta, the way amyloid beta works is the nerve cells. These are cross sections of the cell membranes of nerve cells. The ligand that binds to the receptor that blocks that. If you have the ligand, so if you look at the diagram on the right, the presence of the ligand will block programmed cell death. If the ligand doesn't bind to the receptor, the cell undergoes programmed death, cell death. Amyloid beta actually binds to that receptor and blocks the binding of neurotrophic ligands that prevent cell death. So amyloid beta promotes cell death. And amyloid beta is made from a precursor called amyloid precursor protein, APP. And it can be cut 2 different ways. On the right, if it's cut at 2 different places, we end up with amyloid beta and soluble APP beta and other peptides. If amyloid beta is cut one way, we have the the soluble APP alpha and the CTF alpha. So on the right, those are anti-Alzheimer's molecules, whereas if the amyloid APP is cut in several different places, that results in this quartet of molecules that promote Alzheimer's disease formation. And this is the type of balance we see often in other diseases as well. For example, in osteoporosis, there's a balance between the osteoblastic activity and the osteoclastic activity. Plastic means you're promoting cell maintenance and growth. Clastic activity meaning the cells are dying. So in osteoporosis, there's not enough osteoblastic activity to balance the osteoclastic activity. In cancer, it's the other way around. We have too much cytoblastic activity and too little cytoplastic activity. Same with Alzheimer's disease. The imbalance in Alzheimer's disease is we have too much synaptoclastic activity and not enough synaptoblastic activity. And that balance is maintained by how the APP molecule is cut. This is an analogy given by Dr. Bredesen. So if there are 36 different mechanisms leading to Alzheimer's, and imagine you have 36 different holes on the roof. If we're just plugging up one hole with a single molecule intervention that works on one pathway, obviously we have little chance of success. We want to identify as many of these holes as possible, and that's the integrated holistic whole person approach. And then try to plug up as many of these holes as possible. In laboratory studies has showed the size, the presence, and the size of these holes. So this is a classification of Alzheimer's, subtypes of Alzheimer's according to Dr. Bredesen. So type 1 is inflammatory with a hot type, and factors that could contribute to the type 1 inflammatory Alzheimer's is the standard American diet, or SAD diet, dairy, stress, depression, physical inactivity. Type 2 is the atrophic type, or the cold type, which results from nutrient deficiencies, fat dysbiosis, or imbalance in the gut microbiome, hormonal dysregulation. Type 3 is the toxic type. It could result from for example, mercury toxicity or mold. Type 1.5 is the calico-toxic type, which results really from diabetes or prediabetes. This shows the effect of diet on cognitive health. On the right, that is the image of a 50-year-old woman on a Mediterranean diet. And in this image, red is good. It represents increased brain activity. On the left is the image of a woman of the same age, but on a Western diet most of her life. And you can see there's much less activity. All right, so I said I would go into a little bit of detail about the Bredesen Recode program. This is a program based on Dr. Bredesen's work. It's a functional medicine approach. It's a holistic, whole person approach to prevent and halt and potentially reverse Alzheimer's disease and cognitive decline. The first step is to prevent and reduce inflammation, and we do so by optimizing the brain function, including optimizing the microbiome, avoid trans-fat sugars, refined carbs, dairy, fix compromising intestinal permeability, or colloquially called leaky gut. We want to correct insulin resistance. Interestingly, insulin-degrading enzyme breaks down both insulin and amyloid beta. So the insulin-degrading enzyme, or IgE, is busy trying to break down insulin because your blood sugar is always high. It cannot break down amyloid beta. It also addresses potential infections. Second is to optimize nutrients, trophic factors, and hormones. BDNF, or brain-derived neurotrophic factor, that exercise itself will increase BDNF. Vitamin D, folate, B12 are very important. Estradiol, testosterone are important. Also, eliminate the first step, eliminating toxins is important because amyloid binds to toxins, and these include toxic metals such as mercury, as well as mycotoxins that are produced by mollusks. Many people don't realize how prevalent might be, because it might not be visible to the naked eye. I really like this cartoon. This shows that the faucet is on, and we have water overflowing to the floor. And these two gentlemen are busy mopping the floor, not realizing that the faucet is on. And this is a picture that kind of tells us the story of what our current healthcare system is like. Because we have made a lot of advances in medical technology, but a lot of what we focus on is still addressing the symptom. We're not getting to the root cause. So we're busy trying to mop the floor, and we are not taking the time and the effort to realize that the faucet is on. So we really need to go to the root of the problem, turn off the faucet, so that the problem will be solved once and for all. And so we have made progress. There's more ways to go, and I encourage all of you as public health advocates, healthcare professionals to help to educate the public about the importance of a holistic approach, a whole person approach to addressing and reversing chronic diseases, including Alzheimer's and cardiovascular diseases. So those are all the slides I have for you, and I'll happy to take some questions.
I have a question, and probably the answer is very obvious. So you're vegan, and were you vegan before you actually started looking to more depth about cancer and then doing work around Alzheimer? Were you already vegan, or that changed based on your research and what you found, the association with daily diet and the disease?
So I was a vegetarian for a while, and after I explored more deeply, that changed my dietary choices to be strictly vegan. And not just vegan, you can be vegan and still be very unhealthy vegan if you still eat a lot of processed food. So I follow a whole food plant-based diet. So I essentially eliminate processed food from my diet. So whole food means foods that come from nature and its original form without much human processing. So I'll usually tell patients, if you have to read the ingredients, then that's not whole food anymore.
So in that case, when you're working with patients, we know that food is part of a person's culture. And when they are changing, when they are going through treatment and they are told that you have to change your diet, what is the best approach that you use in order to educate the patients about the changes that they need to make, but at the same time understanding the cultural beliefs that they have, especially how food is associated to, the makeup of the person?
Absolutely. So food is often associated with family, friends. There's a lot of social contact with food. So that's why in a program such as this, especially if we're trying to work very hard to revert or at least stop prevention of something like Alzheimer's disease, it's very important to have the family members on board. So the family members are always there at the treatment session, at the visit, so that the family members are on board, and ideally the family members would go on the same kind of diet, so they can be supported. I did the same thing for my mom. When my mom needed to heal herself, I realized it would be much harder for her to do it alone, so I made the change myself, even though I was healthy to begin with. But I felt great after making the dietary change, and I decided to stay on it because I felt so much healthier. And so family members will also if they make the investment into helping their family loved ones make the dietary change, they could also benefit. And also, we want to identify, we want to take some time to take some spiritual history for patients who we need to assess in making dietary changes. Because a lot of times when, for example, if you're craving a certain type of food, if you're craving ice cream or muffin. Sometimes it's because of the emotional connection to that food. Of course, there's the sugar addiction, which is very real. But that aside, there's often a connection. If you're sick when you're young and your mom always brought you ice cream when you were sick, that is going to have a strong connection. You're always going to be looking for that to feed yourself emotionally. So I often ask patients, when you eat, what are you feeling? What part of you are you feeling? And so if you take time to reflect on that for the family members and for all the people who are not trying to heal from Alzheimer's disease or other cancer patients, it's important for them to make the self-reflection and understand what led to their diagnosis.
You know, you talked about the hormonal replacement therapy. I'm a gynecologist, and the Women's Health Initiative that was done around 2003, you know, showing that there wasn't a benefit to hormonal replacement therapy with regard to cardiovascular disease. The average age of these women was 63, and they had women that they were putting on it at 79. But then when they went back and looked at the women who were menopausal in the 50 to 60 range, and that what they're showing, and they're following them up now, and that actually estrogen prevents amyloid deposition, and that women, unless there's a medical contraindication, need to be on estrogen forever, beginning at the menopause, to prevent not only cardiovascular disease and that, not only colorectal cancer and that, but to prevent Alzheimer's.
Yes, and the women's health, the WHI,
Yeah.
the formulation of the hormones study was equine derived estrogen, and often we neglect the fact that there are bioidentical hormones which seem to be safer than equine derived estrogen. I personally don't practice hormone replacement in my own practice. I leave that to experts who are more comfortable with doing that. But I generally promote a healthier lifestyle as a way to promote better hormone health. But thank you for bringing that up.
Yeah, but it's between the age of 50 and 60. Beyond 60, it's not going to help. But if you're seeing women in your practice that are not on hormonal replacement therapy and they're between 50 and 60, you should really then refer them to someone like me.
Yes.
Who put them on, easily put them on estrogen. And, you know, it's interesting, my sister has Alzheimer's, and she's 71 now, had Alzheimer's at 69, refused, even though I encouraged her to take hormonal replacement therapy when she went through the menopause. No, and she's got severe Alzheimer's today. But I always tell the story, there's a gerontologist at Stanford, and I believe he's still alive, but he wrote a book called Dare to be 100. And he said our natural lifespan is 120, and that, but because of genomics and the environment, we don't get to 100. We don't get to 120. Although a lady died the other day at 121, an American, African-American woman. But he says, but we can get to 100, you know, and you have to look at yourself in quarters, you know, are you the first quarter, second quarter, what have you. And so I invited him over to give grand rounds. I was practicing in Berkeley, California. He came over and I introduced him, you know, and again, motion. He said the key was motion, you got to move, you know, and he was a marathon runner, was running marathons in his 70s. I introduced him, and this little old homeless schizophrenic lady somehow got into the auditorium, and my administrative assistant went, out of here, and she went, I don't care who you are what you eat. And he said, that's not my fellow professor that I brought over here, but she's right.
And just curious, when you prescribe hormones in your practice, do you use bioidentical or non-bioidentical?
I just use the reg, but we do it transdermally.
Really?
Yeah, not orally now.
Okay.
Okay, because of thrombogenesis
Yes.
with the oral.
Yes.
So we give them a transdermal patch, estradiol,
Okay, sure.
just the pure estradiol. And then, but what's happening in the Women's Health Initiative, the people that were originally involved with that are following these patients, and hopefully within the next 5 years, we'll have really, it's a randomized controlled trial, 16,000 women on that they divided, so that we'll have the data. But I'm willing to bet that 5 years from now, with all of that data, and that we're going to get back to hormones, estrogen for every menopausal woman. We did that in California with retrospective studies way back in the 70s, and these women were healthier.
So we're definitely looking forward to that data, which is going to definitely shift medical practice
You got it.
all the time. Thank you.
Thank you very much.
Can I ask a question?
Last question.
Really?
Go ahead.
Okay, two.
I just wanted to know if an individual was subjugated to like encephalopathy or some sort of traumatic brain injury, what is that individual's chance of developing Alzheimer's or dementia?
Yes, so that brain trauma itself does increase the risk for developing dementia later on. Like I can't give you a number, but it is a strong risk factor.
Okay, so my dad, he has dementia, but he's 90. And I would say, yes, about 10 years ago, 9-10 years ago, definitely, is when he started with the dementia and just increasingly got worse. Just a few things. He has vascular dementia. So, what is it, is there a difference between, I would think, a regular neurologist and a neuropsychologist?
The difference between a neurologist and a neuropsychologist?
Yeah.
So, that's your question?
That's one of the questions, but yeah. And does a neurologist, who would do this AV PET imaging?
Okay, so a neurologist is a physician trained in neurology to help make the diagnosis of dementia and also understand what are the causes for the dementia. The neuropsychologist is someone who performs the neuropsychological testing. It's a psychologist, so doesn't prescribe medications. Neurologist would be the one to prescribe any workup, brain imaging, laboratory workup, prescribing medication treatments. Another specialist who can potentially treat dementia and Alzheimer's disease is a geriatrician like myself. So if you have people with dementia or Alzheimer's disease, you send them to a neurologist or a geriatrician.
Okay, just very interesting, because I think everything you're saying is very interesting too.
And vascular dementia rarely happens alone. Most cases of vascular dementia, when you really look at it, happen with Alzheimer's disease. And that's surprising, because many of the risk factors that lead to vascular dementia, cardiovascular risk factors that lead to dementia, like diabetes, hypertension, high cholesterol, same risk factors that lead to Alzheimer's disease. So,
Yeah, he was on, it's funny because he was on a lot of medications, high blood pressure, cholesterol, all these, there's like a slew of them, 7, 8 medications he was on. And then, a couple months ago, beginning of this year, we really thought that we were going to lose him. And they, took him off all his medications. He's still here, and he's, I would say, almost doing better, same or better, without any of these medications.
Thank you for mentioning that. That's actually, we see that commonly in clinical practice in older adults. We often have older adults becoming very sick, and they go on hospice for end-of-life care. And in hospice, what happens when you enroll into hospice, you stop all the medications, and things will get better when
Yeah,
you stop all the
exactly.
medications. So obviously, medications have a role.
Right.
But we want to be very prudent in how we use medication and avoid polypharmacy, especially in the older adult population, to avoid polypharmacy and to be mindful of potential drug-drug interactions that could cause a lot of side effects.
Yes, exactly.
Well, thank you very much. Dr. Wang has kindly kindly allowed us to videotape his presentation today, and it will be posted on the Center for Long-Term Care website. Thank you so much for taking time to visit us. We really appreciate it.
Thank you.